Today we have Daniel Ignacio from St. Jude Brain Injury Network, a huge advocate for traumatic brain injury survivors. So thank you for presenting for us today, Daniel. I'll turn it over to you.
Thank you very much, Kim. So it's been a pleasure, and I am honored to be doing the work for the traumatic brain injury community. And so I will be trying to discuss everything that I've been learning in the past seven months on the treatment of traumatic brain injury and the resources that are available. And so, yes, if you would like to access the resources, they are all available at this website. So www.tbioc.org/highcares. And so everything that we're going to be discussing will be accessible through this website. So if you have issues or would like to download or access the slides, they are available here for you. So, okay, so first, let's open up right here. We're talking about definitions and targets. So first one is brain injury etiology, right? So brain injury can occur from a traumatic insult. A brain injury can also come from a cerebrovascular accident, more commonly known as strokes. They can also come from infections like moya or tumor resections. And so no matter how you get the brain injury, right, it spans a number of symptom areas. So physical, cognitive, and emotional, right? We have all of these symptoms, and the emotional things are really these mental health considerations that impact your post-injury adjustment, right? So brain injury spans all of these things. And so now what I hope to kind of get to different points throughout this presentation is, if it impacts all these things, in what order of precedence do these need to be treated, right? Because it's important, right? So like, does it matter where we start, right? Or what needs to come first? And so the second question that kind of will be thematic related is, what do we mean by getting better, right? So when people say get better, are we talking about maximizing, or are we talking about returning to pre-injury abilities, like who you were pre-injury? Or are we talking about maximizing post-injury adjustment, reintegration, right? And so because those are two very different goals, and where you end up is largely guarded by where you're aiming, right? So having these two things is important. And so the next thing is identifying what has changed, right? And because identifying what should be changed and how treatment should be approached, right? And so that's to say that should we be focusing on diagnoses, like diagnostic categories, or focusing more on your unique network of symptoms? Because those are two very different things, right? So in either case, the diagnostics or diagnoses are focused on the network of symptoms, right? Because every brain injury presents differently. There are different models on what we can use to approach this in this way. And so the different rehabilitation models we'll talk about just really briefly. So the first one is the medical model. And so this one's probably the most common, right? So it's unidirectional in the sense that the person is broken, they must now get fixed so that they can reintegrate back into society. But it does not necessarily consider how the environment may need to adjust to also fit the person. So the person, environment, fit, right? Medical models also where you get these medical categorizations for mild, moderate, and severe TBI. So many of you might have heard mild, moderate, severe. So those are primarily medical categorizations based on your Glasgow Coma Scale, if you lost consciousness, length of unconsciousness, or LOC, like loss of consciousness, and duration of your post-traumatic amnesia, or PTA, right? So based on these injury characteristics, you fit into one of these three medical categorizations, right? And so as we know, well, this gets tricky, right? Because what happens if you don't lose consciousness, right? which we know you can get a mild traumatic brain injury or a concussion without having that loss of consciousness. So then you kind of put up in a way where that could be misunderstood. So to capture some of these things, like the neurobehavioral symptoms of the medical model and the person environment fit, there is the community-based rehabilitation model, which is put out by the World Health Organization in the end of the 70s. And so here, this takes into consideration that person environment fit, but they have been criticized, or they have commented that they don't really, in this extension of the medical model, they do not really consider neuropsychological conditions, right? So things that impact your cognitive ability, right? Like head injury, brain injuries, those kind of things. And so here, very recent research, like beginning of this year, RAL 2020, said that about half of the survivors, 40%, have at least 2 neuropsychiatric disorders. So depression, anxiety, and have at least one unmet need. So inabilities to return to work or to school or to reintegrate into their pre-injury roles. And so now looking into these neuro rehabilitation models, there is the learn to participate model, where basically you take a survivor and you teach them in a controlled setting how to participate in their worlds, right? So here we have workshops, right? Structured workshops so that they can go back into their work and be able to generalize, hopefully, those skills. The other model is participate to learn. So this one is more active, community-based, where instead of putting people in these individual silos and then releasing them when they're ready, we take survivors and put them in supported roles in the community so that they participate in their pre-injury roles. And from there, they learn how to generalize themselves, right? So learn to participate or participate to learn. Those are the different models. All of which really follow. And this is kind of one thing that's been coming up in the Department of Rehabilitation, the California TBI Advisory Board, which I'll talk to at the end, the community-based neuropsychological rehabilitation model, which is a CBNPR. And so this is basically the World Health Organization rehabilitation model specifically for neuropsychological conditions like head injury or dementias. So keep this in your front pocket. We're going to come back to this later, right? So CBNPR model. So it's important to note that through these different neurorehabilitation models, I am not suggesting, or no one is suggesting to replace the medical model. I'm just saying there's a time and the place and a circumstance for it, right? So, I mean, there's very little options that you will have if, let's say, you're having post-traumatic seizures or post-traumatic epilepsy, other than neurosurgery or pharmacological solutions like an anticonvulsant like Keppra, for example. But if you're talking about taking that individual with post-traumatic seizures, and now after the thing gets controlled, their epilepsy gets controlled, now talking about how you're going to get this individual reintegrated back in their community, that's where the CBNPR model fits. So, now to go back to theory, right? So like back for anyone, this is the standard hierarchy of needs, right? So Maslow's. And so here at the bottom, there are physiological and safety needs, right here at the bottom. And so the idea here is your needs that are at the bottom, you can't get to these higher needs until you satisfy the needs at the base or at the bottom, right? So safety and physiological needs. So here, this is we're going to be talking about your base needs. So you might be having difficulties finding housing, right? Or you might have unsecure living situation. And in which case, it's really hard to continue and progress and move forward in your rehabilitation without having housing first. And so that's kind of that model. There's also case management. And also just to talk a little bit about some financial resources, because there are some professionals in here. And so this might be helpful for you or for your clients. And so I think this kind of is an important place to put it, because these are your base needs, your financial resources, like your health policies or your insurances, like your SDI, SSI, SSDI, right? And then if you are looking And I'll just pick this because this is a good service. So if you have SSI or have a client on SSI, for example, but you don't want, but they're scared about working because, or SDI or what have you, or SSI. So they're scared of working because they don't want to get their benefits taken. You can call CalAble account, and it's a financial account that will allow you to earn like 26,000. There's a certain amount that will protect you, that will not affect your benefits. So if you have someone who has resources that might benefit, it's a CalAble account. And then also, if you or a client are involved in a workers' compensation case. So I've been talking with Dunamis Alliance and various other workers' compensation organizations like Latino Comp. And so if you're in a workers' compensation case, there is this case called the Wilson case. It's Chris Wilson, who was a firefighter in San Luis Obispo County, and so thank you for the handouts. Handouts are available there, are also available here at tbioc.org/highcares. And so there is a video with Dunamis Alliance, Latino Comp, and St. Jude Brain Injury Network that talks about the Wilson case. So basically, what he did was able to increase his impairment rating so he can get higher compensation due to a catastrophic impairment, due to the psychological impairments as a result of his hypoxic brain injury, right? Which is another etiology, which is basically loss of sufficient oxygen. So then we'll talk about here is different waivers now. So now we're kind of trying to form the base waves, right? So you might have base needs. And so these are the service waivers from the California DHCS. So first one is the home and community-based alternatives, formerly known as the nursing facility NFAH waiver. The provider, if you're in LA or Orange County, they're Libertana Home Health, right? And so primarily assesses long-term services through this waiver. And so next one is HCBS Developmental Disabilities Waiver. And so why this is important is, let's say if you have a client or you or a loved one had received a brain injury as a child or prior to the age 22, you are eligible for this HCBS waiver through Regional Center, because Title II in the Developmental Disabilities Act in Congress maintains that you are eligible through a severe chronic disability if it's manifested before the individual attains age 22. So you would fit a developmental disability if that is your current situation. Then this one, so there are HCBS waivers. So HCBS stands for Home Community-Based Services. There is an HCBS waiver for TBI. However, the HCBS TBI waiver, California is not one of the states that participate in this waiver, according to NASHA. But we do have CalOptima's community-based adult services, right? This is that waiver or similar waiver. And so the services include professional nursing services, therapeutic activity, recreation therapy, social services, one meal, OT, PT, ST, rehabilitation services, mental health services, right? We talk about it's incredibly important, transportation. And so the eligibility criteria are you're enrolled or eligible for CalOptima or Medi-Cal, right? Or if you're 18 years or older and you have a mild, moderate, severe cognitive disorder through an acquired or traumatic brain injury or some moderate or severe dementia, for example, like Alzheimer's, frontotemporal dementia, vascular dementia, or dementia with Lewy bodies, for example. Chronic traumatic encephalopathy would be another one. Repeated concussions, which we'll get to Dr. Umalu. And so at the end. So if any of those waivers are of interest, contact your local DHCS county office. It will differ from person to person. So that is the local zip code finder. And so, and here is Dunamis Alliance. And so basically this is the video if you want to go to our website to listen to the full 40-minute video.
Today, we are excited to have applicant attorney, Mr. John Hernandez from the Law Office of John Hernandez. Mr. Hernandez has over 25 years of workers' compensation experience, plus was a previous workers' compensation judge.
And so we got really high, really important, informative educational materials that are at that website. And so now we got into our base needs, right? So the financial resources, housing, that kind of thing. So now we can expand more to now the love, belonging, the esteem needs, right? And so now that we kind of have these things, this esteem needs, so you might have been in the situation where you or a client or a survivor, fellow of the community, like you might have been working really well here, like doing well, right? Going to work, going to school, and then suddenly one day things change, right? You may have been up here, and then as our support group, many of our support group has discussed, I feel like I'm moving at 100 miles per hour, and then suddenly now I go to 0, right? And so why might that be? So if you take a look here at the top, there's actually more, there's more steps in between here. And so here's an adapted hierarchy. It's based out of the business world. And so here we have the needs that we were just discussing down in the blue. But before we get to self-actualization, which is right there at the top, right? Finding a life, living a life that is meaningful, purposeful, right? Is what we see here is there are cognitive needs in between. And so these cognitive needs, right? These neuropsychological cognitive symptoms, right? What happens when you have cognitive needs? What does that mean for you neurochemically, hormonally, right? What does that mean for you emotionally, right? And even more importantly, when we see this as service providers, is how does that affect your basic needs, right? So as we pursue knowledge and understanding, that is what we mean when we talk about cognitive needs, pursuit of knowledge and understanding of the self, right? So how does all of that impact the basic needs? Well, we go back to the standard hierarchy, right? We have cognition there. So if you have cognitive deficits there, right at the top, right when you're at the top, and so that's a real picture of me trying to get to the top before my brain injury, right? So that is just like I don't know where things are coming from, and so now here in the cognition piece, when you have this issue, what does that say for your basic needs? Things just topple from the inside out. And so what we try to do here at St. Jude Brain Injury Network and at the state level, as well as the local level, is we try to teach survivors and the families to be better consumers of health services, right? Through knowledge, through education, right? That head injury community advocacy through education, right? And so through the pursuit of knowledge and understanding, so that would form our base needs, that cognitive needs there, right before self-actualization, is we have tons of presentations. So like if you go to tbioc.org/brain education, right? And also tbioc.org/highcares, we have had previous presentations in the past 2-3 months, right? So we had clinical pharmacist from Loma Linda, Dr. Ha, talking about medications for brain injury. We've had UCLA Tibetan master musicians talking about relaxation and brain injury. We've had Dr. Eppley from TMS Wellness talking about homeopathic healing. And then just last week, we had neurologic music therapy, Laura Fonseca, talk to our group. And so, for example, if you're wondering what these presentations look like, I have here a teaser from TMS Health and Wellness with Dr. Eppley, who talked about TMS Health, right? So transcranial magnetic stimulation, right? This is another kind of therapies, much like neurofeedback, which a lot of you were talking about, like lens or hemoencephalographic neurofeedback for migraines and that kind of thing. a lot of us really have been saying is a number one risk factor is sleep, like we were saying earlier, and second is mental health.
Absolutely.
And mental health, including depression, addiction, all of these things here on the right.
But more recently, what I really wanted to focus was traumatic brain injury, because we know TMS is very good for depression. It helps patients. About 80 or 90% of my patients get better with TMS alone. And it helps with anxiety as well. But when people have traumatic brain injury, it gets a little bit more complicated. It's not just TMS that they may need. They may need TMS for sure, and TMS might improve. But what I came to realize is that with traumatic brain injury, it goes way deeper than that. In traumatic brain injury, when your brain, that's what we have the skull, right? It's such a precious organ that when it gets bumped one way or another, the pituitary, which is the gland that produces the neurohormones and hormones in general, gets also tucked away. There's a hormone called pregnenolone. Pregnenolone is the mother of all hormones. It all starts with cholesterol. We need to have healthy levels of cholesterol so we can form the rest of the hormones, right? After cholesterol comes pregnenolone. From pregnenolone, all hormones are starting to form. We have the stress hormones, testosterone, DHEA, progesterone, everything is come from pregnenolone. Her pregnenolone level.
Right. And so take notice of what she said there, right? She said TMS has been helpful for brain for depression, right? So, but when brain injury, it's different. So basically what she was saying is that the treatments that are for traditional diagnoses may not work for head injury, or it may be more further complicated with head injury because there are more things that might be happening that we maybe not have considered yet. And so this coming Friday, we have another presentation from Goodwill Assistive Technology Lending Center, right? Fantastic people, Lauren Menning and Kevin Doherty. And on Friday, 11/6, we have Coscolina virtual tour, right? So basically what they're doing and looking into the future is they are looking at biomarkers for brain injury. Because as of right now, we'll talk about how brain injury is assessed and how it's diagnosed, but what they're looking to do is right now there's not a test. And so the biomarkers at Coscolina, what they're doing in their research center, in which they're going to give us a virtual tour on Friday, 11/6. And so if you're interested in these presentations or getting the link, it's at 11 a.m. on Fridays, Daniel D'Agnosio 2 at stjoe.org for the link. And so here is the study flyer. And so basically, if you or a client is interested in possibly participating, I think it's great because what they will do for their research participants is they participate in the research. They'll give you $50 for going over there. If you're eligible, they'll give you $50 every time you go, and they'll assess you every 6 months for up to 2 years. And with every assessment, they'll give you neuropsychological assessment. They'll give you an EEG, electroencephalogram. They'll do an MRI or a magnetic resonance image, and then they'll do a blood panel, and then they'll do genetic testing, and then so they'll do that every 6 months, and then give you $50 for if you're an eligible participant. And so why this is important is you're contributing great research, but you're also receiving great information about yourself, so that you can be a better consumer of your own health. And so if you're interested in this, his name is Nico Fulmer, fantastic individual. Phone number there. And so, yeah, and so I'll answer these questions. I'll answer those questions at the end. And so here, basically, this is what we're talking about. So Jody House, there's a support group every Friday, right? There's the link. I can send you this flyer. It's hosted by Jody House and St. Jude Brain Injury Network, both of which are state-funded TBI organizations for the state of California. We're known as CAT-BI, right? And so that's where it is. So at this point, figure out, here is the hierarchy that we keep revisiting. So at what point, like what needs to be addressed first, right? And so we need to first assess in multiple domains. Seems obvious enough, right? But it is important, right, that when we talk about multiple domains, it's not, I mean, it could be physically, emotionally, and cognitively, but there could be other things as well, right? So one area may be the most obvious, right? Like cognition or, physical symptoms that were the most obvious, right? I can clearly see, I don't have to do an assessment to see some of the difficulties. It's the obvious one. But using the CBNPR model, right? So taking this briefly out of the front pocket, CBNPR model might show that, well, there could be other areas that hold precedence, right? In which case, maybe an person-environment fit, you could put a person with certain limitations, but also certain strengths. And you can put that person with a neuropsychological condition in an environment, in a situation, in a circumstance in which the environment person fit is so perfect that the symptoms aren't really that big of disturbances. And so that's really the shift or the extension from the medical model to the CBNPR model. And so, as we've talked about, some of the more assessments that we can do that we've discussed thus far are genetic testing and hormonal panels. So using like TMS Health, Dr. Claudia Eppley, she's in Southern California, Costa Mesa, I believe, next to the Anti-Lab. And then we have the blood panel for biomarkers, that Casa Colina study. They're in Pomona, right? And so Nico Fulmer, great guy, tell him I said hello, right, if you talk to him. And so now we're going to be talking about next is the MRIs, CT, and SPECT scans, right? And so these may be really, really important, right? But these may really be really important, right? Because if we take a look here, this is a thing that we did with Amen Clinics and Amen University regarding some of this information.
How are you, Fallon?
I'm good. How are you?
I'm fantastic. Thank you for having me.
Thank you for being here. So if you would just give us a little backstory of your journey and kind of how you found Amen University and then Amen Clinics and how it's been helpful to you and the population that you serve.
Right. So through this, the Amen Clinics, a lot of this information so I've gotten from them and kind of integrating it. So I'm trying to deliver a lot of the stuff that I've been learning. It's really exciting stuff, and so I feel really honored and privileged to do so. And so here we have SPECT scans. So this is what they do at Amen Clinics, which is also in Southern California. I believe they have other locations as well. And so here on the left are healthy controls, right? So colors don't mean anything. They're just, the colors are there just to help you orient. So the pink is like the front, and then the green, blue is in the back, right? So the colors don't mean anything, just help you orient to what you're looking at. And so what you're looking for is a smooth distribution, because what this is doing is they're looking at brain activity through blood and oxygen. So what they're looking at is you're wanting this full, smooth sort of distribution. Versus a severe TBI survivor, 12 years post-injury, we see here, it's like all holy, and there's a bunch of holes and stuff, right? So those aren't physical holes, right? Important. Those are holes of activity, or areas of what they call hypoperfusion, right? So there's less blood moving in these areas, indicating that these are probably not as active. And so here, so these are SPECT scans. This is a PET scan. Positron emission tomography. And so here, basically all of those, the different colors, those are basically those strands, those individual strands are basically pathways, right? So axonal pathways. So basically your white matter, if you think about your gray matter, right? Your white matter is the stuff in the center of your brain, right? And so your white matter is essentially axons that are made up of, basically, if you think about them, these are your information highways of your brain. So you send a message from point A to point B, right? These go through these highways. And so in healthy controls, you can go from A to B relatively simply, right? From point A to point B. Now we see how things are kind of jumbled up on the brain injury side. So TBI is a disorder of disrupted brain connectivity. So now if we do the same thing from behavior to response, A to B, or like thought to response, A to B, we see here that the highway is impacted. So we can't actually get from point A to point B like we used to beforehand. But based off of that, what we can do is the brain can learn to go from, well, maybe I can go from point A to point C, then to point D, then to point W, X, Y, Z, and then back down to B. So either way, like I'm getting there, all right? I'm getting to point B, right? No matter control brain injury, I'm getting there, getting from point A to point B, right? So this rewiring. This is what is big in the neurosciences world as of the last 10 years or so, neuroplasticity at work, right? So point A to C to D to B, X, Y, Z, then back up to B. But either way you put it, you are burning more mental gas by doing this stuff here on the right than you are going direct on the left, right? So what does this look like? What does this manifest like clinically in survivors? Cognitive fatigue. It just takes me, I get so tired by like 1 or 2 p.m. and I can't do it. Like I watch a 30-minute television show and trying to track all the characters and the storylines completely wipe me out. And so next assessment that we have is neuropsychology, right? So we're going to kind of just go through this because this can be sort of technical, but basically the fingerprint of TBI is frontal lobe damage, right? Right here in the front, right? Just because the cranial vault or the skull is relatively smooth, right? So when impacted and shifts around in the cranial vault, it's smooth, but because the front has the orbital structures, like for your eyes and things, like and for your nose, there are a lot of bony protrusions in the front. So when it moves around in the cranial vault, there are bony protrusions. So in the front, so primarily your impact are frontal lobe injury. So these may be things like impulsivity, poor planning, poor concentration, executive functions, right? Emotional control, they're getting frustrated all the time, that kind of thing, poor attention, right? And so those are frontal lobe damage. So how can we assess that, right? So here, one kind of test is the APT test, so attention processing test. And so there are different types of attention. I didn't know that, right? So there's sustained, complex sustained, selective, divided, and alternating. And so why all that might be important is here, this is the OSU TBI, remember Dr. John Corrigan, this is them. OSU, their flow of cognitive processes model, which is based off of a Luria model, Alexander Luria from the 70s. But well, that's a different thing. So first, there is alertness. In order for you to cognitively attend to things, you have to be paying attention, right? You have to be awake, alert, right? And then, so in order to be alertness, right? Alert, in order for you to be paying attention. And so why this is important is because if your attention is impacted, which is typical after head injury, so think of the rotational in the cranial vault, is you have problems in attention. And so if there are problems in attention, your processing, your memory, and your executive functions do not work, right? Theoretically is what it's saying. And so some of these executive functions could be things like initiating, right? A lot of family support systems think like they see a survivor and they say they're lazy, right? They don't initiate, they can't initiate anything. Well, I mean, there might be other things that's happening. So let's not be so quick to call them lazy, right? Then there are impulse control, planning, organization, and this is a big one, is self-awareness. A lot of survivors have difficulty with understanding that they have issues, right? And so really just to hide off, and so of course, please consult any physician or psychiatrist before attempting any pharmacological solution. But I just wanted to share that there is a lot of symptom clusters shared between ADHD and TBI. And so from our support groups, right, there's about 30 to 35 plus of us who meet every week at that support group earlier, right? And then we also have a weekly cognitive rehabilitation class. There are about 22 of us in there, one of which is from Western Canada. So I think she's from the province of Alberta. So, international programming. And so from these survivors, we've had now 5 people who've had the same situation where they switch over to a psychostimulant like Provigil, Vyvanse, Concerta, Adderall. These are the ones that they've had success with, and it's changed their neuropsychiatric concerns altogether, right? Like I can't initiate, I'm defined as lazy, I'm depressed, I'm anxious. All those things may be very similar, because like anxiety and depression, like depression, for example, but it may not be like the traditional depression that's treated with an antidepressant. Maybe it starts from attention, right? So maybe, and so if we can get some attention, that might free that up. So if we can get a psychostimulant to relieve this problem, then processing, memory, executive functions may begin to work, right? And so that has been the experience for a number of our survivors thus far with our part of our family, as I like to call them, because that's how I see them. See us, right? We're a family. And so neuropsychology, if you're wanting some additional resources, here's OMID Institute and their website there. So the things that neuropsychology assesses is like language, attention, visual motor, and executive functions, right? But neuropsychological rehabilitation is more than just test scores, right? You can use it in a CDNPR approach, right? So we can use neuropsychology to accommodate cognitive impairment, right? Using these things here, or we can reduce the cognitive load, right? And so with these tasks here. And so all of these things have been combined, everything that I've talked about, all of these are now being combined in, have been combined in this cognitive rehabilitation course that I've developed here at St. Jude Brain Injury Network. We've been piloting it for 3 years. So we're now at the latest iteration, and we just submitted hopefully for grant funding so we can actually have a budget to do this thing. And so it combines multiple programming, right? And so if you're interested, next series of classes starts, will start up at February 6, 2021, and this will be virtual. So we're accommodating to the times. And so assessments now. Other assessments. So we've talked about genetic testing, blood panel, neuroimaging, neuropsychology, right? So the next thing are primarily, this is what we're using to diagnose brain injury currently. This is current. This is how we're doing it currently. So basically it's through self-reported history of traumatic brain injury. And so what we do is we have these psychosocial assessments, and we send these reports to things like Medicare, Medi-Cal, right, Medicaid, right, for additional, to advocate for our community, the head injury community, to get additional services, benefits, habilitation hours, IHSS hours, right? So we do these assessments. High cares, again, head injury community advocacy through research, education, and statistics. And so we do these psychosocial assessments. And so to talk about the leading way that we assess for brain injury currently is the OSU TBI ID, which is put together by Ohio State University, and again, Dr. John Corrigan.
Hi, so I'm just going to be giving you some quick information in regards to the tests that we usually run for the patients. So the first one would be the one that Daniel mentioned, the OSU TBI. So this is a measure that's designed to be administered as a clinical interview. It asks things for any history, such as blows to the head. It asks about any loss of memory, loss of consciousness. And then it also asks for any time in which the patients might have had a time in their life that had repeated blows to the head. So this could be like time in the military, any history of abuse, or any sport-related injuries. So the second one would be the brain injury screening questionnaire. And this one has 3 parts to it. The first part is designed to be determined whether the additional, thank you. So the first part is designed to determine whether a patient may have had a TBI before in their life. The second part is designed to ask about difficulties in daily living that people with TBIs may have already experienced. And the third part asked about any like additional information on the patient's from personal history, such as their birth conditions or any medications that they might be taking. The third one would be the acute concussion evaluation. This one is a fairly quick measure to administer. It assesses for any injuries, injury characteristics. So specifically, it'll be physical, cognitive, emotional, and sleep symptoms. And then it'll also ask for any risk factors that may become complicating factors in the recovery process. Then after that, we do have the mini mental status exam. So that would be the MMSE. So this is a scale that measures a patient's cognitive functioning. It assesses for things such as orientation, attention, recall abilities, and language abilities. The last one that we have here would be the functional independence measure and the functional assessment measure. And it's designed to assess a person's physical and cognitive functioning that may be informed by the MMSE already. So for example, if I were giving the MMSE to Daniel, I would ask him about like his orientation or to person, place, time, and situation. And then I would also ask him, like, Daniel, I would like you to count backwards by 7, starting from 100.
100, 99, 98, 97, 96, 95, 94, 93. Right? And so what we're showing there is, so thank you, Juliana. So she's part of the high cares team here where she's assessing additional patients and things like that. So we do have trained personnel to do some of our reports and that sort of thing in our assessments. And so what we have here is you're seeing that I was having difficulties sequencing. So even though I got the answer correct, there may be something going on that may be really impacting this person in their life, right? So even though they get the answer correct, you see that their processing is slow, they have to count on their hands, and then they count out loud. And so that may be like, you got the answer correct, they scored perfectly, but now kind of extrapolate counting backwards by 7s from 100, and that slowed out loud processing. Now put that into, going back into work, going to, or school, right? You're trying to manage, organize a bunch of different things in your life. And so now those are clearly impacted. And so in the model systems, there are 16 states in the nation that create this TBI model systems network. And all 16 states, California is not one, right? But we are a longitudinal satellite follow-up center, but we're not one of the TBI model system states. All 16 send their data information about TBI and their patients to Craig Hospital, which is in Denver, Colorado. And so they have, the research director has narrowed down to 3 questions, right, that any provider can easily just do to sort of differentially diagnose or consider the history of a TBI. Did you ever lose consciousness? If so, how long? And how old were you when you lost it? Right, so those are the 3 questions proposed by the research director at Craig Hospital in Denver, Colorado, which receives data from all 16 states in the TBI model systems, right, which uses some of these assessments like the FIM and FAM, right? So now this brings us to our last assessment. Of course, there are tons and tons and tons and tons and tons more, but I only got an hour to fit this in, right? So if this is interesting, I'm gonna learn a whole lot more between now and December. So sign up for the December 30th presentation. I'm gonna have a whole lot more, right? So all the things I'm gonna learn between now and then, right? And so we have environmental assessments. And so these are things like, can we maximize the environment so that we can enhance or improve or bolster the person environment fit so that their rehabilitation is as successful and as efficient as possible, right? So one is like assistive technology, huge, right? So Goodwill, they do free virtual assessment, technology assessments, and then they'll send you the stuff in the mail so that you can try it out. You have to send it back, of course, eventually, but at least it gives you an opportunity for you or your clients to take a look, receive the technology, and use it for like 30 days before you shell out however much money it is, because this stuff can get expensive. And so ATEC, Lauren Menning, if you're interested in that, these are some of, this is how you can get in contact with them. Other virtual resources. So this is important, right? So now we're in the age of COVID, right? And so accessing mental health services is difficult enough as it is, right? So now, now you put a virtual barrier in between that. And so now it gets even worse. But there are also, makes things, some things very accessible. So, for example, free Jody classes at Jody House, right? So they do brain injury rehabilitation classes, right? info@jodyhouse.org, right? That will go to Gabby, is her name. If you speak to her at this phone number, tell her I said hello. They're based out of Santa Barbara. And other virtual support groups, right? So we have a support group. Every Friday we have presentations that that I constantly coordinate. But there are other virtual support groups as well. And so, which is really great, right? Because this is awesome. Because then we're on Fridays. Rehab Without Walls is on Thursday evenings, right? There's another head trauma support project on Thursdays. This is in Sacramento. And so get support from us or one of our friends or from all of us. That's the community. That's what we're all about, helping one another. And so low cost virtual therapy. So if you're looking for virtual therapy, I mean, that's the things like now these individual therapies, you can get them from a number of places. The one I'll show here is OMID Institute. Number is 949-502-4721. And they do low cost virtual therapy. And they do so for survivors of mild and moderate traumatic brain injury as well. So they are trained and versed in how doing that as well. So other virtual resources could be like neurologic music therapy. We're in the process of creating another program with Melly Music so that we can take into account how we can use music therapies, particularly music, for the bolstering of neurological conditions, right? So, and then if you're also interested, there's a really great nonprofit organization called Alive Inside. If you haven't looked up the YouTube video, it's basically they bring iPods to dementia patients and they come alive, right? Because there's something powerful about music. It's such a multimodal stimulus that activates more parts of the brain per unit of measurement than, I mean, virtually anything else like on the planet. And so it's music, and it can activate cross-hemispherically. So if you play in the piano, you're using your left and your right hand, it's activating cross-hemispherically. You're keeping time as you're reading the music, right? So you're reading the music, you're processing it, you're looking through it, you're coordinating it, you're receiving feedback while you're keeping time, right? Psychomotor. And so there's a lot of things that are going on that you can take advantage to with neurologic music therapy. Other resources, what has kind of been coming up more and more and more, right? And so a number of survivors through our family have brought this up as well, is Neuro Optometry, which is different from regular optometry and which is different from Neuro Ophthalmology. And so basically here it says, following a TBI, women experience more symptoms and more severe ones compared to men, right? Following a TBI, there is often an interruption in communication between the eyes and the brain, right? And then there are a number of visual disorders that can occur following a stroke, which is also a brain injury. Neuro Optometric rehabilitation optometrists can help diagnose and treat blah, blah, blah for stroke survivors, right? So this is what we're saying is, after a TBI, after a stroke, you can get visual difficulties like diplopia, double vision, or you have to squint, right? And so if anyone here wears glasses or contacts, right? Like just imagine like when you take the contacts off or take off your glasses right before bed and you're having to squint and everything. You could, if you're having to squint all day, ever so slightly, right? That's burning up, that could be another pathway to cognitive fatigue. right? And another big way that this is tested is through convergence, right? So at a certain point, if you hold your finger close enough to your nose, you see two. And then after a certain point, convergence happens, and then the two fingers become one. That is referred to and then as convergence. And so typically a TBI that's impacted as well. Here's another vision, another fantastic vision resource, facebook.com/vision therapy, Dr. Al-Muradi, Dr. Yamam Al-Muradi. She came and spoke to our family. She did a presentation on Neuro Optometry like a few months ago. But yeah, so she's hosting a vision therapy webinar. Unfortunately, I think it's at the same time as this event. So if you're in this event, you missed that event. But you can reach out to her at this Facebook. Next, an important thing to look forward to is the cervicogenic headaches. So these are things where if a survivor is having headaches, these headaches may not actually be traditional headaches. They may be secondary headaches that are actually neck pain that could be misinterpreted as headaches, also known as cervicogenic headaches. And this was brought to our attention by the University of Alaska Anchorage, their ECHO program, which is a head injury community-based program. So looking into the future, we have biomarkers that we've seen with Coscolina in Pomona. That's where that research study's at. What is the clinical significance of these biomarkers? Like, for example, like if you get a chronic traumatic encephalopathy, you have to build up a tau neurofibrillary tangles. What does that mean for you clinically? Then we have community-based neuropsychological rehabilitation model, CBNPR, right? So taking that person and environment fit to maximize rehabilitation gains, right? And so next is looking forward is restructure at the legislative level, right? So these are primarily mental health considerations, right? We need to think of those breakfast questions, right? Can we access, we need to know if there is history of head injury. That should be the number one thing, right? But of course, this is head injury community, so kind of preaching to the choir here. So second is we don't want to create silos, right? So brain injury versus mental health. We kind of get the thing like, oh, I can't work with that. Insurance won't pay for that because it's brain injury. I only deal with mental health. And then you get the converse, like, oh, I only deal with brain injury. I don't deal with mental health. And so we see that these large populations are impacted, like veterans. 30% of OEF, OIF veterans have been estimated to have at least a mild brain injury. Homeless population, current estimates is 60 as high as 70% of the homeless population has a history of traumatic brain injury or some kind of concussion. Incarcerated individuals, 70% are estimated in men and 80% in women prisons. So this is a very, very real health problem and public health concern. And of course, I'm preaching to the choir here, right? And so, but wanting to kind of put in the side notes is California's Department of Rehabilitation. We have established a TBI Advisory Board, of which we have Dr. Chan, which is PMNR at Kaiser Sacramento. And of course, man who needs no introduction, but I'll introduce him anyway. Dr. Umalu, he discovered chronic traumatic encephalopathy and fought the NFL and began an entire concussion revolution. We serve on this board together. There's 13 of us. Half of them are physicians. I'm not a physician. And so I'm a fourth year PhD student in clinical neuropsychology. All in all of this stuff, we're saying California's Department of Rehabilitation, TBI Advisory Board, we're trying to establish secure funding, find out the needs, right? Get a registry, find out your needs, right? The continuing needs of the brain injury community. So I would like to conclude with a warm reach out to all of you, my dearest head injury community. We need to hear from you. Please reach out. Thank you.
Thank you. Thank you so much, Daniel. That was a lot of information. And I would say that Daniel is a student of brain injury resources. So you have his email address. He sends out a weekly email with updated resources. If you are interested in that, please feel free to email him. If you did not get his email, you can email me and I will make sure that you get on that list. We would like to take some questions. If anybody has any specific information they would like to ask Daniel, now is the time.
Yeah, and I'd like to mention the CBNPR model can be helpful because the CBNPR model, I know it works. I know for a fact it works because the SPECT scans that I showed you earlier on the slides, they're mine. I'm a 12-year survivor, so this stuff works, and I know it does. Yes, thank you, Sheila. Fantastic, thank you. Yeah, and I see here that Cassidy asked about brain-gut connection. Yes, there is. And so if you put your email, yes, you put your email in the chat. His name is Dr. Mark Hyman, and he released a docu-series there. I believe they're in the second docu-series. It's called Broken Brain. So Broken Brain 1, Broken Brain 2, and it's all about gut flora and how brain and the gut, basically, it's considered the second brain. And so if you put your email in the chat, I could send you the link to the docu-series. And so Dr. Mark Hyman is his name. Yeah, so anyone in the chat, if you send your information, I can put you on our mailing list and that sort of thing, and so that you can have it.
So Daniel, Nancy is asking about the statistics for the prevalence of TBIs in males and females within the prison system. I believe that's the Essential Brain Injury Guide. Is that where you got that information, or do you have another reference for her?
The other reference, I have to look through on my notes, but basically through the research that we did through the California Department of Rehabilitation. So
okay.
Yeah.
We'll go.
Yeah.
Okay, we can make sure and send that information to her and anybody else that would be interested in that. So we'll get that resource for you. And we have somebody asking about the slides that we just went through, and those are, I'd like for you to refer people to the symposium presentations, Daniel, so that they're able to go there and get the most updated information. So I did send that out to the group, and it will go out again with your CE certificate. So that is that. And Janine, I'm not sure what you're asking for. You gave us your email. What is it that you're wanting? People are typing in their emails. I'm not sure what you're asking for.
Like to be added.
I see a couple of. Yeah, we'll add a couple of the resources people are asking for from your presentation, Daniel, to your handout, and make that available once we have time to type up a separate slide, and then we'll add that to the presentation list. Does that sound like a plan?
Perfect. Yes.
Yes. Okay.
Perfect.
Awesome. Very good. Thank you all so much for participating today. And thank you, Daniel. I have learned a lot from you, and I have the greatest amount of respect for you. You are a 12-year brain injury survivor and living proof that it can be done, and that you have such a kind heart and have opened up your knowledge to so many people and helped so many people. So I thank you so very much. And thank you all for joining, and we will see you at the next session.
Pleasure. Look forward to seeing everyone soon.